Hi everyone, and welcome to a special Ask the Experts webcast on prostate cancer, sex, intimacy and relationships. On behalf of Prostate Cancer Foundation of Australia, thank you for joining us. Now, over the next hour, our panel will go through everything you need to know about prostate cancer and sex, everything you may have been too embarrassed to ask or have found too difficult to research. So things like the treatment and management of erectile dysfunction, intimacy and relationship challenges, masculinity and sexual identity, and the support available to men and their partners. So if you are watching live, you'll have the chance to send through some questions anonymously. So I encourage you, no matter which part of the country you are in, to send us a question and we'll try to get to them live over the next hour. So as we wait for more people to come online, let me introduce myself and tonight's panel. My name is Ricardo Goncalves. I'm a presenter on SBS World News, the finance editor for the network, and I host a show called Small Business Secrets, and I'm really pleased to be your moderator today. Our panel includes Jane Ussher. Jane is a professor of psychology at the Translational Health Research Institute and the School of Medicine at Western Sydney University. She has conducted a number of research studies on sexuality and cancer, including a large-scale study of gay and bisexual men with prostate cancer funded by PCFA. Also today, Dr Michael Gillman. He has worked in the area of male sexual health for around 25 years. He's a member of various national advisory boards concerned with male health and is a current board member of the Queensland branch of the Prostate Cancer Foundation of Australia. Liz McKervey, who has been a registered nurse for 25 years. She's worked as a urology clinical nurse specialist and prostate cancer nurse educator and now PCSN. She loves working with men and advocating for them, completing a master's in sexual health counselling to help men and their partners. And also tonight is Tom Jarvis. Tom is a urological surgeon at Prince of Wales Hospital and Chris O'Brien Lifehouse in Sydney. He subspecialises in functional and reconstructive urology and has a particular interest in improving the quality of life of men after prostate cancer treatment. So thank you very much to our panel for joining us today. I guess to start off with, maybe Michael, firstly, given you've been working in this field for more than 25 years, yes, how has it changed over time?
I think when I first became involved in this field, the sex was very much a taboo subject. And so what would happen is we'd often see men when there was a crisis. Either they'd broken up with their partner or they'd started off a new relationship, but up until that point, they haven't decided to do anything about it at all. Well, nowadays, particularly with prostate cancer, it is an accepted part of the treatment algorithm of people going through this journey, and so therefore they're introduced to it early, and we'll often find men are a lot more comfortable about speaking about sex these days, particularly the younger ones. We'll sometimes get men very young come in with just one episode and worried it was happening, and that never used to happen in the old days. All right, well, we'll talk about more on that a bit later. Tom, what's the most common question you get asked? And keep in consideration, we'll talk about that in more detail a bit later.
Yeah, sure. I mean, as a functional urologist, in this scenario, the question is, what can I do about my erections? And what I find is more interesting is I'd expect that question a lot more often, and there's lots of people who don't ask it. And I find I'm also asking them, you know, what are your erections like? What's sex like? Do you have any leakage while you're having sex or having an orgasm? And I think we've got a lot more work to do to try and get people to ask us the questions to try and make their lives better.
Yeah, we've got some questions coming through, so we'll get to those very soon. Jane, how important is psychology in dealing with the changes men feel?
I think psychology is really important, and that when we're talking about sex, we're not just talking about the body, we're talking about how people feel about themselves, how men feel about themselves in terms of their masculinity. And we know that sexual changes can really have a big impact in terms of depression and anxiety for a lot of men. It can make them feel that they're not a man anymore, and it can make them feel that that life's not worth living. And I've certainly talked to people who've said, I wouldn't have had the treatment if I'd known the effect it was going to have in terms of my erections. But it can also have a really big impact in terms of helping people. So actually the importance of talking about sex, about offering support and addressing those psychological issues.
So Liz, for those men going through cancer treatment, can they still lead a fulfilling sex life?
I believe they can. We need to look at the expectations the men and their partners might have. We need to recognise that there is grief, there's sadness, there's anger. There's a lot of work to be done, but yes.
Okay. Let's go through a bit of a surgery 101 first of all. So, Michael, what happens to the male sexual function after prostate cancer?
With any type of treatment, whether it's a radical prostatectomy where the prostate is actually cut out, or whether I see patients who've had radiotherapy or hormone, one of the problems is the nerves which cause the arteries to open up, and that's what actually causes an erection to occur. They get damaged in some way, whether it's by the surgeon who's actually carefully peels off the cobweb of nerves. There's some damage there, and so therefore we're not getting the proper connection to the arteries, whether it's by radiotherapy, which actually damages the nerves also, but just takes a little bit longer before it kicks in. The problem is that after that, because there is that damage, the arteries aren't opening, the erections aren't working as well as they did before, and the penis is no longer getting oxygenated with blood like it's supposed to. So what we now do is we try and do a rehabilitation program where we keep that oxygenation up to keep the tissues of the penis healthy while we're waiting for the nerves to recover.
So at what stage then, considering that, should men be thinking about maintaining sexual function? Because I would assume that once you're told you've got cancer, you just want it out.
That's correct, and that is exactly as Tom said before, that most people are mainly just interested in getting rid of the prostate cancer in the first instance. But what I say to men, and we'll see them now before the surgery, because this is now just part of the treatment, we say to them there's 4 things we need to think about. Number 1 is cancer, number 1. Number 2, we don't want you to be leaking urine or having to wear an incontinence pad for the rest of your life, so the actual urinary incontinence is important. Number 3 is the erectile function. And number 4 is the psychological part of this. So there's 4 baskets that we need to look at. All of them start straight away. As soon as the diagnosis is made, we put the plans in place. And if they are aware that we're going to cover all of these 4 baskets, rather than just saying, let's get the cancer out and we'll deal with the other 3 later, it's often too late for that. So we want to start it all off. They know what the plan is, and off we go with the 4 baskets.
Maybe before we start talking about treatment, Tom, is there anything one can do to help maintain, I guess, their performance or potency before treatment of prostate cancer?
I mean, I think in all surgery, rehabilitation is well understood and accepted as really important. And what you're talking about is, I guess, prehabilitation. It's before any surgery or radiation or the starting of any medical therapy is commenced. What can we do about that? And I think Michael's absolutely right. It's about, number 1, the discussion of what your aims are, not only for cancer control, but also for where you want to be with your partner sexually after the surgery, what's important for you. You often don't have to think about those things up until these big changes in your life. And when you're given that opportunity, sometimes it's a very good thing. Before surgery, for example, we can sometimes, especially for very motivated men, start some medication for those who can't get really good erections. Just simple things that are used very commonly, and I think we'll talk about them later. But by using them and getting that blood flowing early, getting that blood flowing really well, then there might be some benefit after the surgery. It's early days with prehabilitation. There's not much published on it yet, but there's some theory behind it, and I think it's important to pursue.
Might jump straight to one question because we're talking about erectile dysfunction. If you lived in rural Australia, where would you go for help with it?
Well, I'll answer that to start with. I think the first step is your general practitioner. The general practitioner I see is the coordinator of all of your health, and so therefore you've seen the urologist, you see the prostate cancer nurse if they have one in the particular area, but the coordinating person of all this should be your general practitioner. But there is lots of support available. There's things online, there are prostate cancer nurses available, and if not in that particular area, then we can actually access things online. PCFA has got a very good website on this, Andrology Australia. So there's lots of things that men can do no matter where they are in Australia, and the information is there.
Okay, we've got some more questions which we'll touch on in a few moments' time about penile injections. So I just want to recognise that we've got those coming through and we'll get to them. Jane, before we start talking about treatment, even before treatment at that stage, how does one look after mental health?
Well, I think the key thing is communication that we've already heard. And we know that actually the most important thing is if you have a partner, talking to your partner, and that's actually one of the biggest predictors of both positive mental health in terms of facing cancer, but also dealing with sexual changes. But the second is also talking to other people, so it might be talking to a healthcare professional or also cancer support groups. PCFA have a really big network of cancer support groups that actually address issues around prostate cancer, which is another thing that we can look at in terms of men in rural communities as well. But also acknowledging the impact yourself of those sexual changes. So it's actually being able to talk about it, get help, and actually say, look, this is how it's affecting me. And I think what we need to do is acknowledge that it affects different men differently. So there isn't a universal, and that there might be different ways of coping with it.
Liz, has gender ever been an issue, whether it's a doctor or a nurse, whether they're male or female, when it comes to providing advice, support or treatment?
Occasionally it has. What I tend to do with my patients is I give them the time to get used to the fact that I'm a female and I'm talking to a man about quite personal things. So I let the patient direct. I will often talk about general things. I don't dive straight in. I make sure that they are comfortable, and once I recognise that they are comfortable with me, then we'll go off into the important stuff.
Okay, so let's move now into treatment. Michael, first of all, the basics of erectile dysfunction. It's obviously a key concern. We've touched on it. The questions are, how common is it in general? How common is it as one undergoes treatment, and what causes it?
Okay, just in the general community, we will find that around about, say, 40 to 50% of men over the age of 50 or 60 will have some degree of erectile dysfunction. So it's actually very common. But once the nerves, as we spoke about before, actually get damaged in any way or peeled off or irradiated, then I assume with my patients that most of them will end up with erectile dysfunction afterwards. There's very few that walk straight out of the surgery and everything's working 100%. So they shouldn't expect that's going to happen, although a lot of men think that will because they've been told they're having nerve-sparing radical prostatectomy and therefore they should definitely be able to walk out with erections. So we explain to them why that doesn't necessarily happen. The second thing is we then look at the ways of treating it. As I say to the patients, it actually doesn't really matter how we get the blood in there to keep it healthy and oxygenated. We've got tablets, we've got injections, we've got all sorts of things. And it actually doesn't matter. We just have to find what it is that works for that particular man. And my idea of this is I want them to get at least a couple of erections per week to keep the blood flowing through the thing. This is part of the rehabilitation, and it doesn't matter how we do that. Often through the 12 to 18 months, which is usually how long this takes, we'll change from tablets to injections, whatever works. And so that they're aware that that's what will happen.
What about other factors, basic things like your weight, for example? Has that impacted at all?
We know that the causes of erectile dysfunction are the same things that cause cardiovascular disease. So there's age, there's family history. Not much we can do about our age or our genes, but things such as being overweight, having high blood pressure, having high sugar, having high cholesterol, having smoking, these are the so-called modifiable risk factors. And it's most important that we actually treat those. But these people didn't suddenly get older or didn't suddenly develop vascular disease. Their nerves, they underwent surgery, and that's the main thing. So yes, it's extremely important, but if we waved a magic wand and took all that away, we still have to wait for the nerve recovery, which normally takes about 12 to 18 months.
I think psychologically what's really important is having the expectation that there will be some change. And I think I've certainly talked to a lot of men who didn't expect to have the sexual changes that they did or misunderstood what they were being told. And I think it's really important that clinicians explain very clearly what the changes will be and that make sure that the men understand it. Because I think if someone expects to have sexual functioning after the treatment, after the surgery, a week later or 2 weeks later and it's not happening, then that can be very difficult psychologically. And then going through the rehabilitation without the optimism that I'm going to be able to get something in 6 months or 12 months is going to be very hard.
Correct.
Who do you think that role lies with? Is it with the patient to ask those questions, or more so a doctor or a nurse?
Well, ideally, the clinicians should bring it up, and I think it probably needs to be brought up at every stage from diagnosis by a number of different clinicians. And sometimes we find that particular clinicians are embarrassed to talk about sex, even these days, or that they feel it's not my job. I think it's important for patients to bring it up and say, how is this going to affect me? How is it going to affect my sexual life? And to ask the doctor quite specifically, or ask prostate cancer nurses.
Yes, it's a team approach, and I mean that's the beauty of prostate cancer these days, is it is treated as a team approach. We've got the urologist or the oncologist, we've got the prostate cancer nurse, we've got the psychologist, we've got the sexual rehabilitation. All of it's a team, and all of them should be talking about each aspect of that, even if it's not their area of expertise.
Yeah.
Absolutely, but the patient also can open our eyes, because sometimes we think that things are going very smoothly and we've asked the simple questions and there's been nods, but you know, sometimes it takes the wife in the consultation to say, weren't you talking last night about, you know, wanting to have better erections or leaking every time you have an orgasm? And it takes family members as well. So you've got to speak up for your family and loved ones, and you've got to speak up for yourselves. We try our best, but sometimes we miss it.
Just another question, a general question while we're at it. How much does regular sex throughout one's life impact prostate cancer? i.e. does more sex lead to more or less prostate cancer?
Do you want to answer that?
I think there's absolutely no evidence that more or less sex has any impact on prostate cancer. They've done lots of studies into looking at whether having an ejaculation interferes or changes your PSA and so on. It really comes down to very little. And I think if there was any evidence for it, there'd be some pretty either elated or very unhappy members of the community.
There was one particular study, I think this is where this question's coming from, that showed that the more ejaculations you have, the lower the risk of prostate cancer, which was similar to the breast cancer, that the earlier you start breastfeeding and the more that you feed, there seemed to be a lower incidence of breast cancer. But that wasn't actually shown in the large data when they put it all together, but it certainly created a lot of media at the time, and everyone was saying, well, we need to be having more sex.
We're getting a fair few questions on some specifics, so I want to get to those. So how about we talk about all the different types of treatment, first of all, Michael? Surgery, radiation and hormone therapy, for example, how can they impact erectile dysfunction?
All of them do, and I'll let Tom talk about the surgery part of it, but all of the treatments to some degree will impact on sexual function. With the surgery, it's the most immediate. So when I see men come back, it's, you know, the nerves are actually physically handled and moved, so that's straight away. Often with the radiotherapy, it happens a lot later. Or if they have seeds, a thing called brachytherapy, where these little radioactive seeds are put in and it slowly works its way out. All of the nerves are on the outside of the prostate on their way down to the penis, and no matter what we do to the prostate, these nerves will get affected to some degree. So it's either it happens immediately or it happens later, but the treatment algorithm is exactly the same. We still want to keep the penis healthy and oxygenated, keeping the blood through.
Okay, Tom, run us through some of the possible treatment options and how one person chooses the right one.
Sure. I mean, Michael mentioned before there's not necessarily the right treatment for everybody, and I try and approach with my patients as thinking, you know, we'll do the simple things first, and we'll do the things that feel more natural first. And there is a bit of a stepwise approach. Always trying to make sure that all the modifiable dietary and health and activity and exercise, stop smoking, because they help with people without good erections who haven't had treatment. But most people need a little bit more help than that, and the first step we probably consider is trying some medications, and that's the Viagra, but there's a couple of others, Cialis, Levitra on the Australian market. And they're all slightly different, so I never give up on one, always try another first at least. And then beyond that, we've got a couple of options. There's vacuum devices for the penis. That literally pulls blood, both venous and a bit of arterial, into the penis. And then we normally put a constriction ring around the base of the penis if the patient then wants to have sex. We've got some little injections. We use a very tiny like a diabetic-style needle that goes directly into the shafts of the penis that hold the blood. They work really well. They bypass the nerves, and that means that while the medications, you have to sort of be in the mood, the injections, it'll give you an erection whether you like one or not. And then for those blokes who have tried everything or don't like them, there's some disadvantages of some of these treatments. Sometimes you get pretty nasty side effects. We've got surgery. We've got a couple of different inflatable penile prosthesis options, and they're pretty amazing devices. They've been around for a number of years. They're safe, they're reliable, reproducible, but they give you a bit of a different type of erection than that nice, warm erection that you would have been used to.
I know you brought in some devices that we can bring out in a couple of moments, but this might be a good time right now, Liz, to talk about how you can make men and their partners feel comfortable to ask these sorts of questions, especially at this stage before making a decision.
Yeah. I find that the best place to start is to make sure that the health professional is actually comfortable with the discussion. That is, they need to be happy to have the talk and to get right into the nitty-gritty of the patient's sex life. From there, I think it's about admitting that sometimes we don't have all the answers as health professionals, that it may and will often take a team of people, a team approach to the care in this area. I also think that it's important to remember that this is embarrassing for many people. So I think the use of appropriate humour often does help make people feel a little bit more comfortable. I also think just being yourself as a health professional, just be comfortable. Make sure that when you are talking to your patients that you're taking the time to genuinely listen to what they're saying and take on board their thoughts and opinions.
So Jane, how do you support men when they are looking at these type of treatment options?
Well, I think the most important thing, as we've already said, is to talk about the various options and talk men through them. We know that some options work very well for men, but also there are some men for whom none of the options work. So they can have side effects with the medication, they can have headaches or hot flushes. Some men find the idea of injecting their penis quite abhorrent or quite painful, and the things like the vacuum pump don't work. So I think we also need to acknowledge that you can have very good sex without an erect penis. That people can explore other ways of renegotiating sexuality. And in fact, some of the men that we've talked to in our research have said that their sex lives have never been better because they've had to talk to their partner, they spend longer having sex, and they do other things. So they do massage, they do touching, and whether they've got a male or a female partner, they're actually engaging in other forms of sexual practice that were actually much more imaginative than they did before the prostate cancer.
So Jane, you mentioned some of the side effects, and Michael will touch on those in a few moments. But Tom, before we start getting straight to some of the specific questions, you've brought along some devices, and as we were mentioning earlier, the more comfortable we need to get comfortable talking about it and getting your partners and yourselves talking about it. So run us through what you've got.
So this is the penile prosthesis that I was mentioning before. There's a couple of different parts. It's a pretty niftily designed device. And this is really, the part at the top here is the part that gives you the erection. And this goes deep down into the body, and it actually fills up the two natural cylinders that we have that get pumped with a lot of blood, and the pressure in those cylinders gets nice and firm, and that gives us the rigidity. And what we do is we basically place these in those natural cylinders and allows us to fill up with blood. You've got a reservoir here to hold the fluid, because you don't want it up all the time, and a pump here that sits into the scrotum under the skin. This is all inside the body, and it allows the transfer of the fluid from the reservoir up into the two cylinders, and that gives us the erection. We've got a penile vacuum-assisted device here, and this is, you can buy these online, sex shops. You don't need to see a urologist necessarily to get one of these and give it a go. And sometimes it's just about getting the blood into the penis. That's what often we want soon after the surgery. However you do that, we don't really mind. You don't always have to have sex every time you get an erection. And this goes over the penis, and there's a pump here that you activate, and that creates negative pressure in this cylinder, and pulls the penile, the penis in there, as well as the blood. And then there's a couple of rings, got all different names, cock rings, penile rings, and they sit at the base of the penis and they hold the blood in there. As you can imagine, though, it only holds the blood at the end, so it's a bit of a floppy penis. It's not as warm because some of the blood is venous blood rather than just nice hot arterial blood. So these aren't the same as getting your natural erection, and therefore we often like you to try the medications and sometimes the injections first. Not for everyone.
So Michael, run us through the side effects of all the possible treatment options.
Okay. With the tablets, and it doesn't really matter which tablet we use, the common side effects are facial flushing, so a flushing in the face, headaches, nasal congestion, upset stomach like some reflux. So they're with the on-demand tablets that are taken just prior to actually getting an erection. We have a daily dosing where you take a small 5 milligram tablet that's taken every day. Its most common side effect, if people get one, will be backache, so they'll get pain in the back and the lower legs. It's due to pooling of blood in the long muscles because this is on board the whole time when you take it each day. With the injections, the real side effect is a prolonged erection. That's the main one that we don't want to happen, and in fact it's considered to be a medical emergency, even though men will often say, well, actually that doesn't sound like a bad thing, you know. But if the penis is erect for too long, we're not getting the fresh blood coming in and the old blood going back out to be oxygenated in the lungs.
What does too long mean?
Basically, if the erection's lasting for longer than 1 hour, we get them to reduce the dose. But if it's been up for 2 hours and it's not going down, they take some tablets to try and constrict the blood vessels to make it go down. If another 2 hours goes by and it's still up, they take 2 more of these tablets, and if it's been up for 5 hours, they need to present to an accident and emergency department where blood will be actually drained. Now, no one wants to go to the accident and emergency department with an erection. So the whole idea is this should never happen in the first place. And if we use the correct dose and we use the correct mix, it shouldn't happen. So we instruct men very carefully on how to use this and increase it gently and carefully, not double the dose or something like that. With the other thing with the injections is there's some things such as bruising if it's not done correctly, scarring if it's done repeatedly or incorrectly. But most of the time, if we instruct people how to do it very carefully, the side effects are minimal with the injections. The tablets, you'll either get them or you don't. A lot of men find that after a week or so, the side effects tend to abate. So if it's not too bad, I will get them to keep going with that for a while. But if they're intolerable, we'll try one of the other tablets because there's not just one size fits all. Try the other tablets, try the injections, whatever we can do to get the blood.
Right. Since we spoke about penile injections, we've got quite a number of questions on them, so we'll go through them. One is, in rural areas, few health professionals are knowledgeable about penile injections. Consumers need to fend for themselves. Where can one get reliable information about the penile injections available?
I mean, that's always, access to good healthcare is always a challenge. And I think even if your health professional doesn't know how to do it, they can learn. And you've got to encourage them to do that. So if you've got a good GP who can look after everything else in your area, encourage them to get out and find out about it, because it's not just people with prostate cancer who have problems with erections. Diabetes is another really common area. So there's lots of people out there that could benefit from it. So you've got to make, and if you're unhappy with where you're getting healthcare, you might have to do that one episode of travel. I can normally teach my patients fairly quickly. Yeah. I have great nurses who can teach the patients. And it's just the really simple, basic things that need to be taught. And then a guy does one injection and he's normally doing the rest by himself.
Another question, are needle-free devices for penile injections available in Australia?
There is some experimental stuff being done by one of the compounding pharmacists in Sydney, the idea being that it's not the needle going in, but it still is experimental at this stage, and I don't think many large trials have been done on it as yet. So at the moment, people are concerned about the injection, and I totally get that. But remember, we're not injecting into the head of the penis, it's into the base, into the shaft of the penis, which is similar to the scrotum or the earlobe. It's actually not a sensitive area, even though we all like to think that the penis is very sensitive. It is on the head, but not on the shaft. And so most men, when they've done the injection, and you would have seen this in your practice, and we all have, it's actually painless, right? And it's the same type of needle that a diabetic uses, And when you think about this sensibly, there is no way a child with diabetes would inject themselves 2 to 3 times a day, every day. If it hurt them, you can't tell them it's good for them, you can't tell them it's good for their health. They just simply wouldn't do it. So it is painless, it's more the thought of it, and once we've actually taken people through and shown them how to do it, it's usually absolutely fine.
The number of times that patients say, is that it? Is that all it was? Yep. You know, and you've reassured them all the way, and you've brought to the point where they're confident and ready to do the injections, and they're like, wow, that was it? And they just love it.
Jane, I guess it's a good point then to bring back the whole psychology of things. We have another question here saying, I'm terrified at the thought of implants and am very nervous about injections. What can I do? I feel like as though my sex life is over.
I mean, I think it's about talking to a clinician who has experience. We've got really good clinicians here today who are actually giving examples of how they talk to their patients, how it's important to have the right expectations. And I think using these sorts of analogies, like a child wouldn't inject themselves, talking about the fact that the shaft of the penis isn't as sensitive as the head. So to actually reassure people and then taking them through the treatment. And I think that the comment showing about I'm feeling devastated because my sex life is over is just really a good illustration of how traumatic this can be for people. That I think one of the things that used to be said when people talked about sex and cancer is, oh, it's just about sex. You know, you should be thinking about survival. But sexuality and sex is really important to people's identity and their well-being. And so these are really important issues that we need to take seriously and talk about and help people through.
Tom, maybe one for you. If injections and pills are not working, how long should you wait before considering penile implant?
I think you've got to take a step back and see how important, you know, getting an erection is in your day-to-day life, and you need to have a good chat with your partner and see where you want to be, because you've obviously been through a big surgical procedure or a big treatment with radiation or hormones, and you've had a negative outcome. So you have to kind of know where you want to go. In terms of time, there's no right time. You drive the time. If you really need an erection and we've given you a good go at trying a couple of different oral medications, we've given you a good go at having a trial of a number of different types of injections and seeing how you go and how you tolerate them. If you're not winning, I think you're ready for a penile prosthesis. But at the end of the day, there's normally a bit of time that gets injected into that. People like to recover from their surgery. People like to, you know, make sure they've tried other efforts before they consider more surgery. And so people find their right medium generally, but there is no right time. Sometimes we go and do the penile prosthesis quite early.
So given that we've gone through all the potential treatment options, how similar will sex feel with these options, say, to pre-surgery?
Yeah, so probably the best normal feeling erection will be one after the medications, because they're just helping the body's natural processes. The injectables, they interfere with sex a little bit in that you actually have to do the injection in the lead up, but beyond that, you've got a nice, warm, firm penis. The erection pump devices, they're a little bit different. A bit of a floppy penis at its base. It's not as warm. It's not as firm, but it's still very, very usable. And the penile prosthesis, quite a different thing. You can get a nice firm erection, but interestingly, the head of the penis is not firm. And that, when you look down at it, you see maybe your penis doesn't look as long, and you've lost a little bit of fullness at the head. And sometimes it can be a little bit floppy and not as warm. Quite a different erection. And that's why it's important to figure out what you're going for. Is it just about penetration? Is it about enjoyment? Or is it about an orgasm? Or is it all above? And I think once you know, we can help you try and achieve that as best as possible.
Also got a question here about sexual urges, and it says, having your prostate out takes away your desire for sex. You still want sex, but there is no arousal to keep an erection. The feel of sex and orgasm is totally different also. Do doctors or do nurses understand this, is the question that's being posed.
I think many do, yes, understand that there are differences in sensations. This is an area that the way the orgasm feels post-treatment is something that is being looked at in a number of research projects at the moment. However, it's not always about the erection and it's not always about the penetration. It's about understanding the big picture, the relationship. It's about acknowledging that with some education and support, you can actually look at your repertoire and alter that and actually increase and improve other areas of your relationship.
Jane, we've gone in detail about the possible treatment options. Does it matter or differ if you're homosexual or heterosexual?
There are differences in terms of gay sex and heterosexual sex, and some of the things we've been talking about are relevant there. So generally, you need a more erect penis for anal sex than you do for vaginal sex. So having a penis that isn't completely hard can make a penetration harder, more difficult for gay men. The absence of ejaculate, which is very common after prostate cancer treatment, is also more difficult for many gay men because the visibility of ejaculate is more important in gay sex. And it can also be different for men who are the receptive partners in sex. So some gay men will actually change from being an active partner to a receptive partner after prostate cancer in a way that's not there as potentially an option for many heterosexual men. So there are potentially positives in terms of gay men because they have options that are not there for heterosexual men. And we found in our research that many of the gay men were more open to exploring alternative forms of sexual expression that Liz was just alluding to. We also found, though, that a lot of the gay men were more anxious about sexual changes because being sexually active was really important to them and really important to them in terms of later life as well. So they had an expectation of maintaining sexual activity into older adulthood. I think what's really important from a clinician's point of view is not to assume that a man is straight, that a man is heterosexual, because a lot of the gay men also felt that they were invisible and their types of sexuality were invisible because their clinicians assumed that they were heterosexual or didn't feel comfortable talking about gay sex.
What about also a general side effect of having no interest in sex? The question, could it be a mental thing as well, and can therapy help also?
I think for some men, having no interest in sex and complete absence of libido is really traumatic because being sexual and having that sex drive is really important to many men. So actually dealing with the loss of that and the grief of that and potential anger at that is, I think, really important. But actually, other men find other modes of fulfillment and other modes of feeling like a man still. And also, as Liz was talking about, the relationship is really important, other ways of being in relationship with others. So that's whether that's a long-term partner, a male or female partner, or for many men, particularly gay, many more gay men have casual sexual relationships. So it might be a way of actually negotiating those casual sexual relationships in a different way, and having psychological support can really help with that.
Okay, maybe one barrier to entry or barrier is the costs involved with these types of treatment options. Tom, what are they?
Michael, yes. So
Michael,
basically, that's right. Yeah, with the tablets, one of the tablets has actually come off patent, so it's actually cheap. So the one called sildenafil, which is similar to the Viagra, we can now get for about $2 to $3 per tablet. The others are still expensive. You're looking anywhere from $15 to $20 per tablet. And for the daily dosing, it's around about $180, $190 around that, or maybe even a bit higher. With the injections, there's a thing called Cavaject, about $15 to $20 per injection. Sometimes we can get little bottles made up of different things from a compounding pharmacist. That tends to be cheaper. The bottles often are around about $105, $110 or lower for a 3-month supply. So we're looking at about $5 or $6 per go, or slightly cheaper. And then with the surgery, well, and Tom will explain this, it depends if you've got private health cover or not. If you do have private health cover, the out-of-pockets aren't too bad depending on your level of cover. Everyone wants to know the exact amount, but it's almost impossible to give a quote for everybody because of the different levels of cover and the anaesthetist fees and everything gets bundled together. And if you don't have private health cover, it's actually quite expensive. For seeing a clinical psychologist, and this is most important that I think people need to do this for some psychological care, they can get a thing called a healthcare plan done through their general practitioner. And the healthcare plan allows them to have the initial 5 treatments, which will be funded under the Medicare system, and then do another 5 after that if they need to. And this is available, and having sexual dysfunction following an operation like this does fit into the criteria of a mental health care plan.
Can we talk about any future prospects for advances in technology when it comes to treatment? Is there anything on the cards there? And I ask that because we've got one specific question. I had both sets of nerves removed last year. I also had radiation treatment and I'm currently on ADT. I'm 45. Advised I'll never have natural erections again. Is there any prospect of nerve graft surgery in the future for someone like me?
It's Tom.
So nerve grafting has been tried and tested in very small clinical trials. The problem with nerves are that they're more you can't just patch them in. They have their own little cells and they have a lot of extensions beyond those cells. And when the extensions and the nerve bodies are damaged, it can knock out that whole link. And so just putting one end to another doesn't necessarily mean it'll work. And that's, I think, a lot of the experience that we've been having. And so there really isn't a kind of a simple way. There are a lot of experimental things. Obviously, these tend to happen overseas because of the greater population group. And people can look into them, especially in the United States, Canada and Europe. But obviously access to that is very difficult. There are some very small trials that are done locally, but they're more of an exception rather than the rule.
We might move on to the psychology of things. And of course, if you've got some questions, send them through. And this one is quite interesting because it says for men with erectile dysfunction who are without a regular partner, we've spoken a lot about those that have got regular partners. Any suggestions with approaching a new relationship?
Again, I think communication is absolutely essential. With any new relationship, we're talking about our past, we're talking about where we are, but it's about broaching that topic of sex with any new partner, and this one just needs to be taken with a little bit more time, a little bit more, I suppose, sensitivity, and making sure that you feel safe with this new person and explaining the situation, explaining where you're coming from, your thoughts and feelings. And I also think that if you are getting positive sort of responses from a new partner, then if you feel it's appropriate, then seeking help from allied health professionals, whether it's a sexologist, whether it's a nurse, your GP, and looking at getting, I suppose, that extra assistance. Jane, do you have something to add?
Yeah, and I very much agree with what Liz is saying, and I think what we also need to do as clinicians is recognise that for many people who are not in relationships, it's very difficult because we're saying talk to your partner about it, but if you don't have a partner, that's actually quite hard. And we know that there are many men who avoid engaging in any sexual relationship or engaging in, any future intimate relationship because they're afraid to raise this issue. So I think helping somebody potentially before a relationship to rehearse how they might tell a new partner. But I have to say, I've interviewed and talked to a lot of men who have been in this position, who've had very positive experiences when they have broached this with a new partner, whether it's a male or female partner, have been able to talk about it and put it in the context of what's actually happening, what we might do about it, and have actually had very positive responses.
Why do you think that is?
I think it's people who have the confidence to do it. I think there are some men who never go into a new relationship because they're afraid, but other men have a sense of confidence in themselves and might think, well, I know I'm still valuable as a person. I'm not the only reason a person is going out with me is not because of my erect penis or because there might be things I have to do to get an erection. And so having a sense of value in yourself. And actually, again, as Liz said earlier, using humour. So it might be finding a way of talking about it that's making not necessarily a joke of it, but saying, look, this is what's happening, but there's other things we can do. And actually, partners can be very receptive. We had one person who we interviewed actually had a penile implant, and he described himself as Robocock, and he said he was actually gay, and he said he used to go to gay saunas and he'd show it off, and he said it was amazing. He got far more partners with this penile implant than he'd ever had before. Now, I'm not sure if he's necessarily a typical person, but it's an example of using humour to be able to talk about something that someone else might find really quite embarrassing.
And so, given we're talking about partners and either a new partner, what about the existing partner? What do you think is their role in this?
I try and get the partners to come into as many consultations with the patient as possible, because they have a really important role to play, and I think they just bring a whole new perspective. They've been around for a long time generally, and they know the patient better than I do. And so when I ask a question and don't get the answer that they want to hear back, they can speak up. And you realise that it's more. I mean, I can give them an erection, but if they're not going to use it or don't want to use it or don't know how to use it, it's not going to be any good. So having the partner in there and educating them, getting them to be confident with doing injections, using the pumps, building it into their foreplay can sometimes be a really enjoyable thing too.
Talking a lot about support, Liz, can you tell us, is it the same for heterosexual and gay men, or are there differences when it comes to the need for support?
I think most people need support. It's part of human nature. We're experiencing something that's incredibly scary, that is changing how we view ourselves, how our partner might view us, how we view the relationship. And so I think it's about, as clinicians, about stopping and thinking about that bigger picture of the relationship, but also allowing our couples, whether they are same-sex attracted or heterosexual, to actually communicate and get the information across. Ultimately, I think, yes, there are some differences, but I think we're covering a lot of the same ground.
We've got some time for a few more questions, and they go back to the initial stages, so I might take some of those. First of all, who is helping with the incontinence/sexual aspect? Michael?
Usually, once again, we talk about the team. So I talk to the patients about the 4 baskets: cancer, continence, sexual function, and the psychological part of it. It's usually the pelvic floor physiotherapists in the major cities anyway who will do the pelvic floor training before the surgery and after. And the idea is to get the pelvic floor in the man as good as possible so that we can speed up the recovery from the continence point of view. It doesn't have to be a pelvic floor physiotherapist. A lot of the prostate cancer nurses are also trained up in this. Some GPs have also had training in it. So we just find someone who is good at this. The women have often had a lot of pelvic floor training in the past after babies and things like that, but it's something that men aren't used to doing. So they need to be specifically shown how to do it. But to answer your question, I think the main domain is a physiotherapist, pelvic floor. That's where we try to use, and if not, someone else who has had training in pelvic floor.
And is that connected potentially to this next question? I have great urine control 24/7, but when I'm with my partner and get sexually stirred, I leak just a bit as if I had no control. It's only a little bit, but embarrassing and a bit messy.
Yeah. This is something that is very common. I think really underreported, definitely understudied. And there's leaking both with just getting excited, and there's also leaking during sex from the physical movement, but also leaking during orgasm. And the sphincter muscle is meant to relax during orgasm, because that's how the ejaculate would have come out. And it relaxes like it's meant to, but there's nothing else holding back the urine anymore. The pelvic floor muscle exercises are absolutely key, and they should be tried and really, really focused on. Sometimes they're not enough. If you realise that urine's not a dangerous thing and not uncomfortable and won't harm your partner, it's not infectious, then some people, once they've been educated about that, are happy, they accept it. Some people will try a condom because that'll hold back the small amount of urine so that they don't leak. And then some people sometimes even will need some surgical procedures, and I undertake a lot of incontinence surgery, and it ranges from quite simple procedures to more complex.
We're getting also some comments about potentially some successful cases of different, treatments as well. How do you find out more about what is out there too, and what if someone wants to self-educate themselves a bit more and go that further distance?
Look, there is lots of information available, and I think that people should look at that. When you go on the internet, of course, there's a lot of rubbish and people selling you things, and we all know that, and everyone's aware that that's the danger. But if you go to reputable sites, and things such as the PCFA has a very good site on there. If we go to some of the cancer councils, there's a range of things that are done properly by proper organisations. If you speak to your GP, if you speak to your urologist, they can actually give kits. A lot of these things are already made up, you know, as part of the treatment there. So there is a lot of information available. To break it down very simply though, if you're looking at the treatments from an erection point of view, there's tablets, there's vacuum pumps, there's injections, and there's surgery. That's it. If we're looking at the pelvic floor things, there's the exercise, there's a range of incontinence pads, etc., that all have to be done correctly, and there are people who can educate. And I know Liz does a lot of this type of stuff with her patients, explaining how all that works. So the information is there. Just get it from a reputable site.
And I think adding into that, just to reinforce, and I know we've mentioned it already, as well as the more medical treatments, there's ways of looking at other forms of getting sexual pleasure. So that whether that's talking to a sexual health nurse or a psychologist or a sex therapist. And it might be that you might want to incorporate something like a vacuum pump or an injection as part of that, or it might be that you actually do change your sexual practices and see it as something that's a different form at this stage in your life. And some people have said it's like going back to being a teenager again, where they're having sex without penetration, and actually that was quite a good time. So I think it's also thinking about how we might do sex differently.
And speaking of other forms, I guess, Liz, and we go back to this talk about support. How do you find that support for different types of sexual lifestyles?
That's a tricky one. I know that a number of professional associations will often have on their website that their members are supportive of different types of relationships, and it's about, I suppose, continuing to ask the questions of the health professionals that you are surrounded with, and to keep asking questions until you find the support that works best for you and your situation. Not everybody like going to see a psychologist. You might have to find someone that suits you. It's the same as your doctor, your GP. It may take a couple of efforts to actually find someone that suits you.
Okay.
I think this is where the support groups can also be really helpful, because it's a network of talking to other men who have often gone out and got the information themselves. And again, PCFA have a really good network of support groups, both for heterosexual and for gay men. And that's a really good source of finding out who's a good doctor, who's a good psychologist, who's tried a particular device or tried a new technique. And we can learn a lot from each other as patients in whatever our area of illness is, and gay men and straight men do learn a lot from each other around prostate cancer.
We've just got a couple of moments just to wrap up, and I want to give you each an opportunity for some final thoughts. So, Tom?
I think after listening to tonight's webcast, ask us the questions. We want to hear about it. We want to improve your quality of life, and we want to get involved in that conversation with you. And sometimes it just slips through the cracks and it's not good enough of us. But that doesn't mean that you can't raise your hand and step in and really advocate for yourself, because we often do have the answers for you and we're happy to give them to you.
Liz?
I concur. I say keep asking the questions, keep looking for the answers that you need in your situation, and just keep going. Don't give up.
Michael?
I think one of the troubles is when people get diagnosed, they get overwhelmed with information, and often patients will see the urologist, they'll go and see the nurse, they've got a folder like this, you know, and they just get overwhelmed. And I actually say to them, if it was me, right, what I would do in this particular situation is break it up into the 4 baskets. I keep coming back to the 4 baskets. Even put your paperwork in there. Cancer, continence, sexual function, and the psychological part of it. If we can deal with all of those and we do it all properly, we can go tick, 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 tick. Not so that at the end of it, I've still got erection problems. You know, I could have done this and maybe something could have happened. I'm now leaking urine. If I had have done this, I wouldn't be. So think of it in the 4 baskets, tick them off, and we try and get the best outcomes possible for our patients.
And Jane?
Well, I'd agree with what everyone's saying. I think sex is important. It's take it seriously. Know that clinicians do take it seriously and can take it seriously, and talk about it. So ask the questions of your clinician, talk to your partner about it, and actually don't be afraid.
Okay, well, that wraps up our Ask the Experts webcast, which was proudly sponsored by Stellis. Thank you very much to our panel, and thank you to all of you for joining us today too. We hope you have found this information useful, and don't forget the Prostate Cancer Foundation of Australia website has plenty of information and resources to help you gain even more knowledge. I'm Ricardo Goncalves. See you next time.